this tutorial, we'll talk about migraine without aura and chronic migraine. In the first slide, I show the classification of migraine at the 2-digit level. You have migraine without aura, migraine with aura, chronic migraine, complications of migraine, probable migraine, and episodic syndromes that may be associated with migraine. But many of these can be further subdivided, and we can go down even to the 4th and the 5th digit. We'll see examples of that later in the talk. This is an old picture showing marked changes in brain blood flow during migraine with aura. And it's probably a cortical spreading depression. And these were results that were crucial when we decided to separate migraine without aura and migraine with aura way back in the 1980s. At that time, it was hotly disputed whether it should be separated or not. But it has proven that it was a very good idea to separate, because later on there's been a lot of differences shown between migraine with aura and migraine without aura. Not only these brain blood flow changes, genetics, biochemistry, and response to drugs, and so on. So it was a lucky thing to do at the time, and it's maintained and will be maintained in the future. But at the same time, we must say, of course, that they are not two different diseases. They are two different types of migraine. So there are many similarities also. And it continues to be a hot issue to debate, what is the relation between migraine with aura, migraine without aura. In this slide, I show you the diagnostic criteria for migraine without aura. This is the most important set of diagnostic criteria in the whole headache classification, because migraine is the most important headache disorder. And luckily, when we designed these operational or explicit diagnostic criteria for migraine without aura in 1988, the committee had such a lucky hand that the criteria have remained unchanged for more than 30 years. This is very, very good, because it means that all the research done on migraine without aura, all the drug trials and everything, can be rolled forward. If we had changed these criteria significantly, then some other people would be migraine patients than the ones identified with this set of criteria, and we would, in a way, have to repeat all kinds of research and drug trials and everything with the new diagnostic criteria. So for this reason, headache classification has to be a conservative discipline. We can only change diagnostic criteria when there is good published evidence indicating that this should be done. Otherwise, it will remain the same. And I'm sure the new leadership of the classification committee will adhere to this principle. So just to repeat from my previous tutorial, in order to get the diagnosis, a patient has to fulfill all the letter headings A, B, C, D, and E. And one or two of them, the two first ones, are monothetic. The headache there must be at least 5 attacks. They must last between 4 and 72 hours untreated or unsuccessfully treated. Otherwise, patient cannot have the diagnosis. But when it comes to the pain characteristics, only 2 out of 4 characteristics are necessary. And when it comes to the associated symptoms, only 1 of the 2, either nausea and or vomiting, or if they don't have that, they must have photophobia and phonophobia in order to get the diagnosis. We still have this not better accounted for by another ICSD-3 diagnosis. Now, why do we have it? We have it for all the headache diagnosis. We always have it. And it simply is a reminder to people to say, even if your patient, the headache in your patient fulfills a certain phenotypical characteristics that fit into the diagnostic criteria, you are still a doctor. You still have to think about it. You still have to think, is there some other things that some underlying disease that could be the cause? Is there a more likely diagnosis? So for example, a patient starts getting what sounds completely like tension type headaches, but you find out that the patient also has become some slow in mentation, and there may be slight disturbance with the coordination of one arm and so on. And then, of course, you know it's not necessarily a tension type headache, even if it phenotypically fulfills these criteria. You have to go on and find the underlying neurological disease that actually caused this phenotype. Migraine affects 15% of the population, and of course these patients are not all the same. They have the same phenotype, but we're sure that the underlying mechanisms are different, and one day we'll be able to subdivide migraine patients in many different subgroups, each of which probably will have to be treated somewhat differently. The most obvious subtype for migraine without aura is migraine that is strictly related to menstruation, so-called menstrually related migraine or pure menstrual migraine. Pure menstrual migraine, as here is, means that they have attacks only at the time of menstruation, defined as the day of bleeding plus minus 2 days. Never any attacks outside of menstruation. Menstrually related means they have these headaches, but they also have attacks at other times. And there are a number of studies of these headaches indicating that they have some special characteristics, but we still don't have any major differences in terms of genetics or biochemistry. But it's a different subtype that needs to be studied separately from other migraine patients. Now we get to a relatively new entity, chronic migraine. It was first included in the classification in 2004, and later the criteria were somewhat modified. It has proven to be a very important entity. It's the severest aspect of migraine. These are the patients who suffer the most, who are very often disabled, completely disabled by their migraine. And it's defined as a headache occurring on 15 days or more per month, out of which at least 8 days must be migraine. Either migraine without aura or migraine with aura, or a combination of these two. So chronic migraine is different completely from episodic migraine, because episodic migraine is only defined by the migraine attacks. Chronic migraine includes migraine without aura, migraine with aura, and headaches that phenotypically resemble or fulfill criteria for tension type headache. It's just the very severe end of the spectrum of migraine, where it's difficult to tease out the different components. But it's been extremely rewarding to have this, because it's only chronic migraine that responds to botulinum toxin treatment, for example. And in many countries, the new CGRP antibodies are only accepted for chronic migraine in Europe. So there are problems with authorities that migraine is so common, they are afraid of expensive drugs. But chronic migraine is not so many, so it's more likely that we can get new expensive drugs accepted for this diagnostic entity. The most common reason for a migraine to become chronic And it is like that. Because chronic migraine virtually always started as an episodic migraine that then becomes worse and worse and worse and gradually becomes chronic. The most important cause is medication overuse. And when people are taken out of medication overuse without anything else, then about 50% no longer have chronic migraine, but episodic migraine. So always think about medication overuse when you have a chronic migraine patient. It's a rule that patients who have chronic migraine and medication overuse, they must have both diagnoses. And when we then stop medication overuse, they will later have either episodic migraine diagnosis or they will still have the chronic migraine diagnosis. A problem with this diagnostic criteria for chronic migraine is that there are a good number of patients who have migraine on between 8 and 14 days a month and no other headaches at all. And they are severely affected. Just imagine a patient who has 12 migraine days a month, but no other headaches. They don't fulfill the criteria for chronic migraine. They are extremely severely affected. But they cannot get, in Europe, the new antibodies, for example, because they don't have chronic migraine. And therefore, there's been a suggestion from my group to alter the diagnostic criteria and say anybody who just has 8 or more days of migraine a month, regardless of the 15-day of headache, should have the diagnosis chronic migraine. And these are the proposed revised criteria, but they are still only a proposal from one research group, and this whole thing has not been debated in the new classification committee. Status migrainosus is a severe situation where migraine attack just continues and continues. A patient is debilitated by the migraine. So it lasts more than 3 days, more than 72 hours, and the patient is debilitated. The last thing is important because there are not so few, especially menstrually related migraine attacks that last for 4 days. But they are not that debilitating. It's typically a little bit in and out of migraine. Status migrainosus, of course, needs to be treated vigorously and sometimes by admission to hospital. And there's the last thing in this chapter. We have probable migraine. We have probable category in all chapters of primary headaches, not in secondary headaches. And probable diagnosis is given to patients who fulfill all but one criterion for one headache disorder. So if they fulfill all criteria for migraine without aura, except one, then they are probable migraine without aura. But remember that if the same headache fulfills the criteria for tension type headache, not probable, but definite, then they should have the tension type headache diagnosis. Thank you very much.